So once again, welcome to Samaritans Purse International Health Forum. We are more than delighted to have you join us again today. We have a great webinar presentation. I'd like to remind you during the presentation, to the right of the PowerPoint is the chat box, and please utilize that if you have any pressing questions or issues during the presentation. And then at the very end, we have about 5 to 10 minutes dedicated to Q&A in which you can use the chat box as well. So to get started, we're, as usual, going to open up in a word of prayer, and I'm going to call on my colleague, Beth Thompson.
Well, let's pray. Thank you, Father God, for the opportunity to learn and grow today. We just pray that you would be with Dr. Mary as he presents, and you give us open ears and minds to hear and understand, and that the presentation will just go smoothly, Lord. We love you and give you this day. Amen.
Amen. Well, thank you, Beth. I am delighted today to present Dr. Stephen Mary. Dr. Mary is a board-certified family physician who also has his MPH from Harvard University, and likewise has studied tropical medicine from the University of London. In addition, he has received training in essential surgery while serving in Africa. Dr. Mary teaches family medicine residents at Mayo Clinic in Rochester, Minnesota, where he is a proceduralist as well, and he also maintains his own family practice, and he also serves as the chair for the Mayo International Health Program. In addition, he provides direction to Mayo Clinic on global health involvement as a member of the Mayo Clinic Abroad Steering Committee. Today, Dr. Mary is going to be presenting to us about cost-effective care in resource-limited countries. So without further ado, Dr. Mary, I'll turn it over to you.
Thank you, Lance. Well, we'll start on the first slide, which just reminds us that our care here in the U.S. is necessarily different than what we must do in low-income countries. These are the new billing codes from this past fall, and hopefully those of you working in Asia and Africa are not worried about coding to the specifics of being pecked by a chicken or heard at the opera, and this is the sort of silly detail that we get so worried about here in the U.S. Care must be different at your mission hospital. I have no disclosures today, financial or off-label drug use. Our learning objectives are on slide 4, please, and that's treat chronic diseases in a resource-limited setting in a rational, cost-effective way. Secondly, we want to learn how to do income-based diagnosis and treatment of chronic diseases, including cancer screening, as well as reflecting on that for acute care, and learn how to design treatment protocols based on the guiding principles of cost-effectiveness. Next slide. What we don't want to do, please, is just take our U.S. treatment guidelines and export them to a low-income country, treating diseases with no regard to cost, simply on the basis of some sort of ethic of guilt, which is, I'd want to be treated this way, or saying it might be the golden rule or something. The reality is that in a low-income setting, you must give different care. All of you intuit that. We're going to discuss how different it should be today. Slide 6, please. So the overview slide is that when you look at the full gamut of what it costs from the start of accessing care to following up a disease treatment, and ratio that with the benefit in disability-adjusted life years, and do that analysis in the context of the resources of the patient or the family or the employer or country, whoever's paying, then you're going to come out with cost-effective care. That's a mouthful. We're going to talk about what that means. Now, next slide. My disclaimer is I'm a clinician. I'm not an economist. I'm all about how are we going to treat the patient that's presenting to me in the hospital or in the clinic in a way that is cost-effective. And part of my goal today is to provoke thought as much as it is to provide you a final answer on this material. Next slide. A Harvard Business School paper back in 2009 reviewed how to do this in the HIV care setting in resource-poor countries, and came up with this phrase, care delivery value chain, meaning that when we look at the whole of the disease progression from preventing the disease all the way to management of its deterioration, all of that must be taken into account when determining cost. Can't simply look at the drug cost, but we need to think about what that patient paid to come and see you at your clinic. They had to take time off work. They had to leave their village. They had to get on a taxi or some sort of transportation, come all that way to your hospital, stay overnight, have breakfast, then see you, then pay for a meal afterwards, maybe overnight again, and all the way home. And unless you're thinking about all of those costs in the context of the benefit, it's going to be hard to come up with a real rational cost-effectiveness analysis. Next slide. In general, in cost-effectiveness analysis, we look for best buys. We look at what lifestyle changes can be put in place rather than what can we sell the patient or prescribe to them chemically, like a statin for cardiovascular disease prevention. No, we would be looking at lifestyle changes, smoking cessation, more exercise, weight reduction, a change in diet. We express these in terms of cost per benefit, and that's usually US dollars per disability adjusted life year gained. Not just how many years they survived, but how many years they survived healthy. And requires then a knowledge of, in general, the numbers needed to treat for one person to benefit from any sort of particular treatment. Next slide. So what is a reasonable cost? Well, we could come up with a metric that is just, I prescribe something, and if you're willing to buy that, then that's reasonable, and you make the decision. My hypothesis is that we as providers need to help make that decision for the patient. I think the metric which is much more in use worldwide and which is recommended by the WHO is something that deals with income. So they say 1 to 3 times the per capita GDP of a country. That's about how much one disability adjusted life year is, quote, worth. Not what human life is worth. This is a public health kind of measure that I'm suggesting we need to bring into the clinic, in the exam room, into the hospital. My suggestion today is that per capita GDP is skewed for the many poor and the few rich. And so if we use a general GDP rather than that patient's domestic product, we're going to often be in the wrong. So I'm suggesting that what we should do is, with some idea of what the patient income is based on their occupation and our knowledge of that country, come up with a metric that is something like 1 to 3 times the per capita family income divided by the number of people in the family, multiplied out times that multiplier that the WHO suggests. Let's look at some examples. So let's go to the next slide. So I have this first question for you, which you may have received if you're getting CME credit for this, and it's the case of a hypertensive Guinean farmer. You're in the clinic, you're seeing this guy. My context now is the hospital that I'm currently working to develop, Compassion Evangelical Hospital in central Guinea, which serves the Fulanis and the Maninka people of Upper Guinea. And this elderly, at least in Guinea, elderly is my age, Guinean farmer, he's a heavy drinker, he's a bit hypertensive, his BMI is high, so he's obese 1, but his exam is otherwise normal. What would you do for this man's hypertension? So choice A is you recommend some lifestyle change. Recommend that he gets blood pressure checks by a community health worker and then returns to see one of the community. If he has consistently elevated blood pressure above 160 over 100. Conveniently, I put his blood pressure 1 dot lower than that into the mild or stage 1 hypertension category. So you might choose to do that, or you might say, okay, I want to do that, and because this is the only time I'm going to see this guy, maybe I'll start some hydrochlorothiazide. Or you might do both of those and check some labs, or you might do those and also check his cholesterol, initiate a statin and an aspirin if his cholesterol is elevated, and because the blood pressure is elevated, to control associated risk. I'm going to assert today that the right thing to do here is A, to not treat mild hypertension in a population of poor Guinean farmers. Next slide. So when we look at hypertension internationally, it's been defined as stage 1 up to 159/99 and stage 2 160/100. Next slide. Hypertension in Africa is common. Little of it is detected, even less is treated, and a small percentage is controlled. In this study from Tanzania, one of the countries with better health systems for doing outreach kind of care like that. Next slide. And yet hypertension is the leading cause of congestive heart failure in Africa, shown in this study from an urban cardiology practice in Ghana many years ago. You can see that around a fifth of the cases of congestive heart failure are due to hypertensive heart disease, and about a similar amount from rheumatic heart disease. So we know there's collateral damage if we don't treat it when it's significant. Next slide. But just treating it when it's mild, as if that's what we would do here in the US, and so we should do it there sort of thing, is, I would suggest, not responsible use of healthcare dollars. Why? Because the number needed to treat to prevent a cardiovascular death is 700 individuals per year taking their antihypertensive for mild hypertension to prevent one cardiovascular death. Now, if the cost of treatment is at least somewhere around $50 per year, and you say, well, my pills at my clinic don't cost that much, but remember that patient had to come from their village, time off work, go there, stay overnight, eat their breakfast, et cetera, et cetera, et cetera. And so if you add up all of that, we would all say that the cost is somewhere around $35 to $70 per year to treat a case of hypertension. And if there's a 1 in 700 chance that this guy will benefit, you then multiply the 50 by the 700, and you come out with a cost of $35,000 to prevent a cardiovascular death. Now, I'm going to assume that that guy would have lived another 10 years, say. So we divide the $35,000 by 10, and we get about a $3,500 cost to gain one disability-adjusted life year. You can go back to this slide and afterwards if that kind of confused you, or you're post-hypoglycemic after your lunch. But the idea here is that we need to have some idea in our mind of how to do this calculus in a way that then rationally influences our care. Next slide. So the WHO has often done this kind of homework for us. And they suggest that the maximum disability-adjusted life year cost should be about 2 to 3 times the per capita GNP. Again, this is skewed by the wealthy. So I'm going to suggest that the better threshold is the family per capita income. So if this guy's making $200 a year, and he has a family of 4, so he's got 3 wives, no children still at home, then you divide that max daily cost of 3 times his income, or $600 by 4 people, and you get $150 per person per year that we would say would be the maximum disability-adjusted life year gained cost. And so anything that exceeds that cost of $150 is likely to be not cost-effective. And quite in fact, in studies done mostly in developed countries, looking at what people are willing to pay, most of us aren't willing to pay even that much. So here in the US, if our per capita GNP is in the many tens of thousands of dollars, most of us aren't willing to pay 3 times that to save one disability-adjusted life year. And the same is true in Africa or Asia. Next slide. Some of this work, as I mentioned, has been done previously. Here's a beautiful little study that was published back in 1998. It's applicable to my care setting in Guinea, in the hospital that our local church here in Rochester, that has a lot of Mayo consultants attending it, is building. And this author, Ja, looked at the the 40 health interventions, most common health interventions in Guinea, and rank them by cost effectiveness. Now, this is real small font, but what you'll see here is that many of the things you would consider very cost effective, you're right, are very cost effective, like treating pneumonia or malaria in children. What might be surprising on that list is that a C-section for obstructed delivery or surgery for appendicitis is in the very, very low cost, very cost-effective group of interventions. Much less cost-effective are some of the things further down that list, like treating severe malaria in children or treating a severe injury that might require more prolonged hospitalization. At the very bottom of the list is treating hypertension in terms of cost-effectiveness, even less cost-effective than treating AIDS or mild malnutrition in children. Next slide. So I would submit to you that mild hypertension should not be treated in a low-income setting. Next slide. Now, if we change the scenario and we make this guy a 35-year-old, so if we prevent a cardiovascular death, instead of living 10 years, we might say he's going to live, well, maybe another 35 years. Then, and we make this a business owner, so he's making $2,000 a year. Then given the same number needed to treat of 700 to prevent a cardiovascular death, gives us a cost of treatment of $1,000 per disability adjusted life year as a threshold. And so then if this guy has 6 people in his family, and we then take the 3 times his $2,000 annual income, divide it by the 6 in his family, we come out to $1,000. So in fact, I would treat a 35-year-old business owner making that kind of a salary with those kinds of numbers of people under his roof. Next slide. Whereas if I also had a 55-year-old business owner with stage 2 hypertension, now I've got a number needed to treat that's somewhere around 35 per year to prevent 1 cardiovascular death. So with more severe hypertension, it becomes much more cost effective, and I would treat that individual even in the elderly. Next slide. Again, some of this has been done for us, and what we as medical missionaries often do wrong is we assume that we know best because we trained in the US or we trained in Europe, and we know the best way to treat patients even in these low-income countries. And the fact is, we haven't been trained well to do cost-effective care. Thankfully, some of this homework has been done for us, and you'll find it in your local country's therapeutic guide. Every country on earth has, and you can find it in a link at the bottom of my presentation on the WHO website, has a therapeutic guide that goes through what the Ministry of Health recommends we follow for different chronic diseases. And I would recommend you use that. Look here on this Guide Thérapeutique, sorry, I'll use my French, Guide Thérapeutique National in Guinea. This is a little statement here of what they're defining arterial hypertension as. So rather than saying hypertension is 140/90, in Guinea, we're going to say hypertension is 160/95. Redefining what is disease and what is not helps care providers to then say, well, I can ignore everything under that and worry about lifestyle changes in the people that are borderline. Next slide. So who do we treat? Well, it depends on their risk, their access to care, their availability of meds, the comorbidities, and the household finances. All of that goes into the decision, and I would submit to you that's our ethical injunction to really do this cost-effectiveness analysis rather than throwing that back on the patient. Next slide. Now, some of you will say, that's rationing. This is the Oregon experiment. We don't want to be involved in this kind of thing. But I'm saying rather, no, this is exactly what we, as those who are providing holistic care, must be involved in, is really caring about the whole person rather than just prescribing pills. Next slide. I'm not saying that life isn't worth more than that certain threshold. Of course, we do the same thing here in the US. I wouldn't do an MRI for every patient that walks in with shoulder pain, and I wouldn't do that because it's not cost effective, not because it wouldn't give me some additional information. So that's my my assertion today again is we need to do the same thing for the poor in low-income countries. Next slide. So if we don't practice in that way, you need to ask yourself this question: where is that money going to come from? If that 55-year-old or the 35-year-old is paying money for treatment of his hypertension, that's money that could have been used for children's nutrition or a wife's prenatal care. Maybe he has more resources than his income on the other hand. You know, he's got a rich uncle in the city or here in the States, and maybe a barter economy might mean he's got more of an ability to pay than really his income would suggest. All of that needs to go into our thinking a bit, and this is the kind of treatment protocols that will help us as we design them for our hospitals and clinics. Next slide. Remembering that if we don't treat, there is damage, there is risk. And I mentioned one, and that's congestive heart failure. Could have a CVA. There could be disability that would lead to this breadwinner of the home really needing additional resources from his family. And maybe he won't come back. Maybe this is your one opportunity to treat, and you need to make that decision then. And then someone would say, well, you know, he came here to be treated to my hospital. How could I send him home just to get follow-up blood pressure measurements rather than treating him when he came here to get care? Well, if he came there for care for some other symptom, headaches, fatigue, it wasn't his hypertension causing those, right? We know mild hypertension, even severe hypertension until it becomes an urgency, does not cause much in the way of symptoms. And your pills aren't going to make him feel better. They might even make him feel more fatigued. They're simply decreasing his probability of a secondary event. Next slide. If you do decide to treat, I would base it on exam in very few labs, maybe just a dip UA and at most a creatinine. Getting a potassium and an ECG, lipids, and a fasting blood sugar or calcium like you do here in the US is not cost effective. Slide. And then I would start with something that's cheap, has few side effects. I'd give the patient a ton of them so they don't have to come back for a year, increasing the costs if they do, and see you back in a year. And probably see the healthcare worker back in a year and you back much less often. And then maybe every so often doing a dip urine like every 5 years or doing your exam to check on comorbidities. Next slide. We can use risk stratification. So if on your primary encounter with this guy you see that he has congestive heart failure, you see that he's actually has some renal insufficiency, or he simply has grade 3 or severe hypertension, then of course you're going to treat him because the numbers needed to treat are very, very low. Next number. Remembering that there's a whole lot of benefit to be gained by lifestyle modifications. Don't discount what you can do by simply recommending the patients lose weight or eat more healthy diets. Here in the US, patients are often looking for a quick fix. My patients in Africa understand that it might not be that simple. They may need to actually change their behavior. They're a bit more prone to do that, I would say, than my patients here in Rochester. Next slide. The patient needs to know that this will be lifelong treatment. They need to take their medication daily, and it may not make them feel better, but it is good for them if they're going to be treated. Next slide. And the medicines that you give should be cheap and convenient with very few side effects that really effectively reduce risk, not just lower numbers. Next slide. And AllHat showed us, that study from years ago showed us that all the meds have about the same benefit. Thiazides are cheap, they have few side effects, and they actually are superior in congestive heart failure prevention. Calcium channel blockers work best in Africans if you're in an Africa setting. Next slide. And this is shown from a New England Journal study back many years ago showing the percent of patients that respond to diltiazem much higher than the next best bet, which is hydrochlorothiazide. Next slide. So I've got in the next couple of slides some little choice recommendations about what you could do in those settings. And let's go to 3 slides down past the next one and to this next one right there. So In a cost-effectiveness study just published this past fall in China, they modeled low-cost essential hypertension meds and said that even in China, with their economy, treatment of stage 1 hypertension is not cost-effective at even 1 times the GDP. So now the final recommendation in that paper was to go ahead and treat it anyway, demonstrating the ambivalence we have as care providers to recognize things that benefit little and yet we can prescribe something for. Next slide. Remember, when we're looking at best buys, those best buys are all lifestyle things, are mostly lifestyle things. There's a few others like immunizations and other public health measures that are very, very low cost, very high return in terms of cost-effective reductions in disease. Next slide. This kind of cost-effectiveness analysis, as I mentioned, has been done for us at the WHO. You can find there this One Health tool if you ever get into public health and want to model some of these sorts of interventions. Next slide. And there's publications there that discuss whether or not and how to be involved in chronic disease screening and treatment in a cost-effective way. Next slide. So my conclusion and my assertion to you is that we shouldn't practice there just like we practice here in speaking of the US, and that someone else has already thought this through, and the Ministry of Health in your country, whatever you think of the quality of their staff, is really diligent about trying to figure this out and put into practice guidelines that really will do cost-effective care for their country. And you should integrate with national practice standards. Next slide. So then we've got this second case of a Togolese boy with type 1 diabetes. This little guy lives in a village with no electricity. His family lives on less than $2 a day per person. And his father, now after his hospitalization of a few days, tells you as the care provider he wants to discharge his son home to die. You would, choice A, get angry and give Dad your man-up pep talk. Well, I mean, that's what I clearly remember doing in Togo for a type 1 diabetic that was about 7 years old once. And so this is a natural response. What do you mean you want to take your son home? I just saved him from his DKA. He's going to need to be on insulin the rest of his life. Or you'll keep him hospitalized and you'll think about it tomorrow. Or you'll find funds in the hospital for home monitoring and insulin, tell the family to move where they can store the insulin in a fridge and have all those resources. You'll support them through the hospital to the tune of many hundreds of dollars per year. Or choice D, you have a compassionate discussion, you evangelize he and his dad, pray with him and discharge him home per his dad's wishes. And I would submit to you that choice D is not an unreasonable choice. It is, in fact, what is usually the end result in low-income countries. Next slide. The fact is that type 1 diabetes is a terminal disease in low-income countries, and so we need to hold our Western indignation because our colleagues trained in low-income countries are trained knowing that. Next slide. Only about 1 to 3, maybe 4% of the patients can even access insulin in low-income countries. That means the vast, vast majority of type 1 diabetics die. Now, I'm not, next slide, saying that this is a good solution or a final solution in a new heavens and a new earth, and not what we should be pushing for in terms of equality and equity around the world, but it's a reality. And if you burden that dad with the responsibility of here's this many hundreds of dollars of cost, you need to make the decision. And if you poor farmer, are such a poor schmuck you can't afford this medication that you'll let your son die, then I'm putting that ethical burden on you as the dad. I would submit to you that that's bad care, and it's not Christ-like. And I would submit to you we instead should be having a heart-to-heart talk about what life is and what life in Jesus is, rather than what prescribing the the latest, greatest thing is, just like we would do if a kid came to you in Guinea or Togo or Cote d'Ivoire with renal failure, and we wouldn't send them for renal dialysis to the U.S. It's the same idea here. I'm going to pause right here for station identification because I'm not sure how much time we have left. Samaritans Purse friends, what are we looking at for additional time? And I can't hear you because I think you're muted. So you can hold up your hands and give me how many minutes I should keep going. How many minutes? Can't hear you, I'm sorry. Hello? How many minutes do we have left? Lance? Lance, how many minutes do we have left? Five minutes?
No.
Sorry to jump in here. Dr. Mary, if you're able to stay with us for the full time or for a little while longer, you're welcome to present.
Okay.
You're welcome to keep going with your normal presentation. Sorry for the interruption.
Nope, that's fine. So you can put me back on, and here we go. So next slide. So let's look at the case then of a 60-year-old type 2 diabetic. So we've got a guy here that lives with his son, who's a subsistence farmer. This older gentleman is himself inactive. His son does the work in the field. He helps out a little. And you examine him. He's obese. You've already found out that he's diabetic based on his history of polyuria, polydipsia. You found he had some elevated blood sugar. What would you do? You would, A, advise weight loss exercise and an aspirin a day as the most cost-effective. You would, B, do that and add some metformin. You would, C, check a creatinine and only do metformin if he doesn't have some renal insufficiency greater than, with a creatinine greater than 1.5, the U.S. treatment standard. You would, D, do all that, but also check his cholesterol, add a statin to control his LDL less than 100. Again, that's what I do with all my patients here at Mayo. Or D, plus adding an ACE inhibitor and recommend home glucose monitoring. So I would like to suggest that both A and B are reasonable choices in a low-income country setting. Next slide. And diabetes, type 2 diabetes in Africa, and I think in Asia as well, although my experience is much less there, comes in a couple of forms. There's the obesity form, which is 90% of what we see here in the US, but much more common in Africa than here is a type of type 2 diabetes where the patients are actually have a normal body mass index, normal weight for their height. And it does respond, though, to oral agents. It's not type 1 diabetes. Lifestyle change, however, makes little difference in these patients. Much of this literature comes from Rwanda and other East African countries where it's believed that it's either genetic or due to infection, pancreatic disease, or toxicity from, for example, poorly processed cassava, often from not soaking it or using one of the new grinding and preparing methods. So this kind of type 2 diabetes is not as amenable to lifestyle change. And so these patients will need oral agents. Next slide. But for the obesity-associated type 2 diabetes, tight glycemic control has very little to do with morbidity and mortality. Now, if you are trained here in the U.S., as I have been and most of you listening have been, you've bought into Big Pharma's idea that lots of medications are better than no medications or few medications. And expensive medications are probably better than cheap medications. And I'm here to tell you that that's inappropriate thinking and not true. with one exception probably. Obesity, inactivity, and bad behaviors are what mitigate risk, and correcting those reduce the risk. Next slide. The Mr. Fit trial started us off on the wrong foot, believing that the residual in deaths due to coronary artery disease in diabetics must be not due to a need for aspirin, lipid-lowering, blood pressure control, and smoking cessation. So therefore, these diabetics must need blood sugar lowering. And if we do that, we're going to cure their problem with cardiovascular risk. Next slide. The fact is that was a bad assumption. Lowering sugar does not eliminate risk in type 2 diabetes. Next slide. And we've learned that now from multiple studies. We learned it way back in more than 20 years ago when the UK PDS trial was starting to be published, and finally in '98 in the Lancet UK PDS 33, the 33rd publication of that trial, demonstrated that tight control of type 2 diabetes doesn't affect mortality much. And endocrinologists looked at that and said, well, maybe if we just had a higher N, not a many, a couple thousand, but many thousands, then we'd see a difference. Well, that's getting silly, isn't it? So next slide. We had the ADVANCE trial published in 2008 that demonstrated not only is tight control not good, it doesn't make any difference in cardiovascular death, non-fatal MI, or stroke. Next slide. And then the ACCORD trial, published at the same time in the New England Journal in June of that year, showed also no difference in MI or stroke and increased all-cause mortality, which I would suggest to you is the nail in the coffin of tight control, anything less than somewhere around an A1C of 8. Next slide. Rather, what we should be focusing on in low-income countries particularly, but I would suggest also here, once the metrics change for what is good care, is smoking cessation, it's weight loss, it's Mediterranean diet, it's exercise, it's normalizing blood pressure and giving aspirin. These are cheap interventions compared to the diabetic glycemic control interventions, which we should reserve for symptoms that are not well controlled, patients that are having polyuria, polydipsia, and need treatment for that reason. Next slide. Now, the cost of medications expressed in days' wages is on this slide here for glibenclamide and metformin. And in fact, metformin is a fairly affordable medication in most countries. It's on the WHO essential drug list. And that's the prior slide to this one we're on currently. But let's stay on this. Yeah, go back to the slide you were just on. Yeah. So until September, this past September, Zinman and all published in New England Journal this study showing that empagliflozin, one of the new diabetic agents, actually does decrease mortality. But until that, metformin was and still is the only other medication that has been demonstrated to decrease mortality. To say it in the converse, all the others that have been studied for their effect on mortality have shown no difference. That includes insulin and sulfonylureas. So I would use those for symptom reduction, but not for control of A1C as if that is our primary target. Reducing cardiac risk should be our priority, not reducing the A1C primarily. Then if the patient can afford it, they can get retinal monitoring and laser retinal treatment for proliferative retinopathy, or be on an ACE inhibitor if they have microalbuminuria and they can afford it, lowering their fasting glucose as income allows. Next slide. So I'd submit to you, if this guy has the funds, that I would do metformin as well as lifestyle interventions. Next slide. Now we have the case of a pregnant Togolese woman. This woman comes in, she's had one prior uncomplicated pregnancy delivered by an untrained traditional birth attendant in her home. And she's coming for prenatal care because she heard that, you got to go to the hospital to get really good care. And so she comes there at 12 weeks gestational age. What would you recommend? Would you recommend monthly visits increasing to every 2 weeks at term with hospital delivery? It's what we do here in the U.S. Or recommend she simply, again, deliver at home with the traditional birth attendant. She survived it once, why not try it again? Or number 3, recommend care with the maternity in town at term. Or number 4, recommend that she get tetanus prophylaxis, iron folate, insecticide-treated bed nets, be on preventive treatment intermittently for malaria, and have a prenatal visit in each trimester with a midwife or a physician and deliver with a midwife. I would submit to you that the first one is completely irrational because frequent prenatal care has been demonstrated to be no better than infrequent prenatal care once in each trimester. I would suggest that delivering at home with the traditional birth attendant is Russian roulette. Many women die from that. Many more babies don't survive birth. I would recommend that she deliver at the maternity, but that she get care during her pregnancy with all of those choices in D. Next slide. And this is so that we do improve maternal health. Here shown on the Millennium Development Goals, the MDGs have been phased out into the SDGs, some amorphous multiple statements about goodness, but we still are working, next slide, to reduce the marked maternal mortality and infant mortality that accompanies inadequate prenatal care and delivery care around the world. Next slide. And that means that women need antenatal care. In most African countries, that's very difficult to access even once, as shown in this slide. Next slide. Because we know that skilled attendance at birth saves not just mothers, but their babies. So women should deliver not by a traditional birth attendant, but a trained traditional birth attendant or midwife. And trained traditional birth attendants are a bit of an oxymoron, at least according to the studies. When we train a TBA, usually that training does not, if you will, stick, and they return to prior practices that are equally harmful. If you do put them through prolonged training and mentoring, I'm sure that is not true and that they will become much more effective in their treatment. Next slide. So good maternity care requires what's on this slide, as I already mentioned. Next slide. So case 4, the right answer is that whole group of treatments and preventions for safety for that mother that will assure her a safe pregnancy, a safe delivery, and a healthy baby. Next number. If she's unable to deliver vaginally, then a C-section is highly cost-effective. On that list of health interventions in Guinea that we saw at the start of the presentation, it's one of the most highly cost-effective things we can do for reducing maternal as well as infant morbidity and mortality. Next. In fact, all of essential surgery, by its very title, essential, is highly cost-effective. So whether we're treating trauma or doing cleft lip and palate repairs or inguinal hernias or male circumcision or cataract surgery, these are very low-cost interventions that markedly reduce suffering and death. Next. And these are things that generalists should be doing. This report back from Dr. Chu in 2009 in PLOS Medicine recommended, she's a general surgeon working with Médecins Sans Frontières, currently in South Africa, and she recommended that generalists like me and like our scrub techs, I would suggest, in the hospital, should be doing this broad range of surgeries, draining abscesses, burn care, doing C-sections and herniorrhaphies, appendectomies, and being adept at skeletal traction. Next. Because simply training general surgeons to do general surgery is not going to meet the vast need of this very neglected set of diseases that comprise what is cared for in essential surgery. And if we wait for that to be the solution, then we will continue to have islands of good care in a sea of misery around the world where many, many cannot access care and die because of a lack of surgical care. Next number. So what about cancer screening? The fifth case I put in your pretest was, what should we do for screening for cancer? Well, in fact, cervical cancer screening is the one cancer that is cost effective to screen for. And screening women at age 35 and 40 are both very cost effective when using visual inspection of the cervix with acetic acid. So that's a technique of simply doing a speculum exam, spraying the cervix with acetic acid and looking for aceto-white changes on the cervix, and biopsying if you are able to get biopsy results, or right away treating with cryoablation or a LEAP or loop procedure to remove the transformation zone there in the cervix to eliminate the risk of cervical cancer. That will markedly reduce cervical cancer, the most common women's cancer in low-income countries. Next slide. But not colon, breast, prostate, or liver cancer screening. We can prevent liver cancer with treatment of hepatitis B and C and prevention with Hep B vaccination. Next. All of the lifestyle and public health interventions for infections as well as chronic diseases are highly cost effective, and I'll let you, as I cough again, read through that list. Pardon me. Next slide. Again, a reminder to look at the patient, not at their numbers or their disease. We want to be treating the patient-oriented outcomes that matter, not just what we see, but the actual cause of those, like tobacco, poor diet, alcohol, and so on. Next. Sorry about my cough. So caring for people in resource-limited settings in a cost-effective way means less testing, less specialists, less physician care, more public health care, avoiding futility, and it means having primary care well available. If your hospital in a low-income country is not the center of a large community healthcare outreach, you need to do that. Next. Limited labs, maybe choose one or two as you're writing guidelines. Pardon me. Rarely using imaging, examining the patient carefully. And then instead of referring to the capital city for specialty care, making wide use of virtual consults or textbooks. Next. Using syndromic diagnosis like is used in the Integrated Management of Childhood Illness, or IMCI, where, as in this example, pneumonia is diagnosed by its cardinal signs rather than by a chest x-ray. Next. Here in this report on Thailand, these guidelines show that screening, even in a middle-income country like Thailand, is not cost-effective for most cancers. Next. So cost-effective care means, in terms of treatment, pills, if the treatment saves a year of disability-adjusted life for less than 3 times the per capita household income, is my assertion. Next. It means then not treating things that really don't need treatment, like my upper respiratory infection. I shouldn't be on antibiotics for this cold. That would be silly if I ask for it. It's viral, it won't help. Most otitis media, we know, will cure itself, about 14 out of 15 cases, with no antibiotics, which are widely overprescribed in the US. Same for conjunctivitis. Area daycares in Rochester years ago required that we prescribe antibiotics for the child to return when they had pink eye. Well, that's silly. It's a viral illness the vast majority of the time. The same for sinusitis and bronchitis. Don't use medications when they aren't needed. Next. The WHO's essential medication list, which can be found there at its most recent form, should be consulted for the medicines used in any guidelines that you draw up in your hospital. And then medications purchased should be from an essential drug source like IDA in Holland, if it's allowed in your country. Recently heard Cameroon is not allowing the import of IDA meds for I'm not sure what reason. Next. Cost-effective care means task sharing or task shifting, such as I'm suggesting should be done in essential surgery, where the general surgeon shares the responsibility for some of the surgery with generalists or technicians, avoiding futility, not treating diseases that are inevitably going to lead to death, but rather handling those kinds of cases in the appropriate way, the way Jesus would, were he to not heal the person, with dealing with their soul issues rather than their physical issues only. Next. So how should I decide who to treat? Well, we need to do some mental math, and then we should consult the national treatment guidelines for the country we're working in. And sometimes that means simply, in a respectful way, asking our national colleagues, hey, what would you do in this case of mild hypertension, learning then that that's not appropriate to treat in that setting for a poor farmer. Next. I would suggest that you carry with you many resources. And the two that I would suggest are just fabulous is Dennis Palmer's and Catherine Wolf's Handbook of Medicine in Developing Countries, which is published by CMDA, and the Oxford Handbook of Tropical Medicine. Next. Pardon me, everybody. Well, medical missionaries behaving well in a low-income country follow the Ministry of Health treatment protocols. They work cost-effectively, screening for and treating diseases at high risk for adverse patient-oriented outcomes that matter when cost-benefit is reasonable. And they focus on community transformation to prevent and treat diseases by working on root problems rather than patching it up with pills when possible. Next. So those are our learning objectives. I trust that we have covered those sufficiently, and I would like to take questions now, if there are any.
All right. Dr. Mary, I just want to start off while we're waiting for questions. I just want to thank you. That was an excellent presentation. I would submit to you, with the rising cost of healthcare in the United States, that we could take to heart some of those recommendations that you mentioned. Certainly, lifestyle modification, getting to the root of the cause of some of these chronic illnesses. Your approach is very, very practical, and I think it's applicable to all of us, not even in resource-limited countries, but certainly, especially in there. So.
Right. Yeah.
And then also, I really totally agree with you that we need to integrate our behavior to the national practice standards there, and we can learn a lot from our colleagues, nationalist colleagues. So thank you for that excellent advice.
Thank you.
Yeah.
I think the sort of pride with which we often walk into these situations, especially as short-termers, which I'm saying this with transparency, I was one myself.
Yes.
Is what needs to be killed. We need to kill that pride, recognize that our national colleagues, the nurses there on the ground, have been doing this for years, and even though they may be doing something different and we aren't sure why, for us to discount that out of our own pride in our mind and say, well, I'm going to do it the American way, and push our guidelines on them is really short-sighted and harmful, and so yeah, I think the goal is to work as a team,
Yeah.
and in providing truly patient-centric care.
Exactly. Yeah, we have much to learn from one another, and as you said, our colleagues there, they've seen it just over and over again. So I think we can bring something to the table with our high technical training, but we have much to learn from them. That they know the culture and the what's relevant in their community. So we need to pay attention and take heed to what their advice is.
Yeah, absolutely. Our European colleagues often have a much more cost-effective approach to these diseases.
Yeah.
Our own healthcare costs are twice our nearest competitor, and yet we're getting infant mortality rates that are the 30th highest in the world, and so on. So we've all heard that kind of data with healthcare reform talk, but it's completely true that we spend way more money to get very poor results here in the U.S., and those of us that then train in that kind of system where anything goes, order any test, do anything, even for terminal disease, I think it's time we learned to really treat patients in a way that that meets their need rather than our own.
Right. Amen. Yeah. I totally agree with you. And as I said, with the rising cost of healthcare in America, what your advice is going to become progressively more relevant. So I can't agree with you more. But Dr. Mary, I'm surprised I got a silent audience here. I don't have any questions coming your way, but again, I just want to reiterate our great thanks for an excellent presentation.
My pleasure.
Yeah, I think that will be very applicable for us as we all provide care in developing countries. I want to remind our listening audience about CME with our email. Please just follow the directions to submit your CME. I want to remind you that you need to submit it in a timely fashion. Ideally, we can get it in within 1 week. So after that, we may have difficulties granting you that CME credit. We will be sending out in the very near future a video link, a recording of this presentation, and so I encourage you to keep that for your archives. Also, just want to remind you that in our last email that we had a link for DART applications, Disaster Assistance Response Training, so that you can participate with disaster response at Samaritans PERS in the future. So I encourage you to do that. And then in closing, next month we will be presenting again on the second Wednesday, March the 9th, at 12 noon Eastern Standard Time. The subject is to be determined. Thank you so much for joining us. God bless, and we'll see you next time.
Thank you.
Thank
Bye-bye.
you.